Thank you all for joining us today at the Sanobil Perfusion Symposium Shark Tank, sponsored by Quest Medical. I'm Ophira, the MPS sales manager for the Southeast region of the US. This is Parker, the MPS sales manager for the South Central of the US. And this is Amy, and she's the MPS sales manager for the Northeast. She'll be presenting our speaker today. Please stop by our booth today after the Shark Tank. Feel free to have some Bloody Mary. There's a bar on each side.
Tyler Kelting is the Director of Perfusion at the Maine Medical Center in Portland, Maine. He graduated from the SUNY School of Perfusion and has worked at the Maine Medical Center for 13 years. Tyler has been the director for 5 years. He has served a 4-year term on the American board and is a co-chair for the AMSEC Leadership Symposium. Tyler has a passion for leadership and data analytics and has pursued an MBA in organizational leadership and implementation science. Tyler is a proud father of 3, a 7-year-old and 3-year-old girl, and a 9-month-old boy. The title of Tyler's talk is MPS, Navigating the Winds and Gales of the Operating Room, where he will share the 20-plus years of experience that his hospital has with the MPS. Please join me in welcoming Tyler to the podium.
You did great, Amy. You crushed it. Good job. How often do you have a stage where you can just sit in a comfortable chair while you get that introduction like that, too? Not to mention having Bloody Marys during your talk. Makes this probably one of my favorite talks that I'll be doing. Just to start out, one disclosure is I do have no financial disclosure or conflicts of interest. Although this is sponsored by Quest, I have received no financial impact of this. My thoughts, though, however, like many, are based on my own empirical data and studies done at our center. And although I haven't received any financial contribution, because I wanted to make this talk really authentic at the same time, I did obtain some slides from them for visualization purposes. So as Amy did a great job introducing me, I just want to share a little bit about my center. You know, it's fairly old. We've been doing we've been doing surgery there since 1868. And here's a picture of it on the right. And ultimately, we have 12 different hospitals that feed into this big institution that we've really grown over the years. We're now up to 13 perfusionists, just over 800 ICU beds, 32 CT ICU beds. And as you can see, this building here in the bottom center of the picture is this $500 million cardiac tower that we're going to be launching here in a couple months, which we're pretty excited about. And just a shout out to really my team and my hospital for allowing me to be here with you all today. A little bit about the center that, you know, I'm proud of is, you know, we've received the 8th consecutive Leapfrog Teaching Hospital Award for Top Teaching Hospitals. It's an independent organization that comes in and looks at quality, safety initiatives, how you do training practices. We made the U.S. News World and Report for best regional hospitals. Our nursing is magnet recognized. 2 years ago, we received the AMSEC Pillar Award for best in quality and practice. And then we also have the Gold Center of Excellence through ELSO. So as I think we can all agree in this room, you know, as we start this conversation, is healthcare is getting more complicated. And, you know, I hate to just constantly go over the fact of COVID. We always hear about it, but, you know, ever since then, we've definitely been seeing older patients, sicker patients. Techniques are advancing. You know, you can see some of these monitors here on the right. A lot of what we're doing, you know, is data, more data, to the point of, yeah, we have all this data, but we don't really know what to do with it. We have AI algorithms now coming on the forefront of driving healthcare in the future, and I'm going to talk a little bit about what our center plans on doing that in the upcoming months and years. Prescriptive care is really being dialed in at an exponential rate. You know, we don't really do this one-size-fits-all We have multiple, care plans now that are being developed almost universally at institutions. Precision-based care is really becoming a duty and an expectation. And, we're really trying to reduce clinical permutations much as possible. And, to really think about how impactful that is, just look at, our center. We have 13 perfusionists, 12 anesthesia providers, and 7 surgeons. So that on any given day, that's 1,092 different ways that cardiac surgery can be done by those individuals in the room. We try to standardize as much as possible, but I think for large centers, it's very rare that there's one type of cardioplegia that's being utilized by all surgeons the same way, same timing, same dosing, same strategy. And because of that, we're trying to come up with ways that we can think on the fly. We can react accordingly. It's not stressful going into these situations where we're really trying to customize the care to the patients that are being presented towards us. So this is where the MPS 3 comes in. And it really is kind of like the Swiss Army knife. You can do really any ratio, any strategy, and we'll go over about different ones that we're doing at our center. But whether it be microplegia, whether it be traditional del nido, whether it be micro del nido or a variation of it, buckbird, custodial, plegiosol, this can do it. And if the surgeon has to switch their algorithm on the fly, it's no factor. So some of the different things that we use it for, and for time purposes, I'm not going to get in on depth, on all of these, but various permutations of cardioplegia, as I listed in the previous slide, and as we'll get into on the next slides coming up. One of our strategies, we can use it for retrograde cerebral perfusion. This is one of many techniques that we can use if we want to do it that way. We can use it for left heart bypass, which I'll go over in the next slide, just a little bit of our algorithm for doing that. Change of plan on the fly. And, this is where I have this, picture and quote from the famous catcher of the Yankees. When you come to a fork in the road, take it. You think you're going left, and then last minute, they're like, oh, patient has dissection. We're actually going to do this. Or you know what? It actually just turned into a CAP 2. Tyler, can you make this happen? Where before, now we're switching out solutions. Now it's simply just hitting a couple buttons. We're good to go. There's nothing you have to do different on your end. And the surgeons love it. Graft perfusion, which I have some great pictures of. But that's really been a game changer in using the auto-regulation function. I really do think it's the safest way to do it, and it's certainly the most stress-free way of doing it. Cold agglutinins, sickle cell patients, whether you're doing warm continuous, and for those that have done warm continuous, it's kind of stressful. You're doing it for 40 minutes, 50 minutes, surgeons cranking up the heart, you're getting high pressure alarms. Well, here you can kind of auto-regulate it to pressure. The flow is going to do what it wants to itself. The pressure is going to stay the same. You can focus on the patient and all these other parameters that are becoming more a part of our more complex heart-lung machines. Intermittent cold cardioplegia with a sanguinous del nido afterwards. You can do that as well. And then also, for the end of our cases now, we actually use the vent line, which you can see in booth 2 after the talk if you want to see more information on it. But we can actually suck over our circuit preliminarily using the vent line with the cell saver. So nothing needs to be done on the surgical field. The surgeon loves it. We're not taking their cell saver. The scrub loves it, so they can do their counts. And meanwhile, we can do what we need to get the blood to the patient at the right time, the quickest time as possible. So just to dive in a little bit of our left heart bypass work, because I think this is important. When we do left heart bypass, we can use it with or without the heart-lung machine, or I should say with or without an oxygenator and full cardiotomy. But on times when we're just using tube in, centrifugal pump, tube out, there's a lot of times our surgeons will be like, look, this is a complex left heart bypass, a lot to do on the descending aorta. We're going to be dealing with the mesenteries. We're going to be dealing with the kidneys. I want to perfuse them. We can do that with the MPS, and it's completely separate and isolated from the rest of the heart-lung machine. And here you can see my very elementary drawing and photo here that I took. But ultimately, we put solumedrol and mannitol in that lactated Ringer's bag with just an auto transfusion pack, and we can prime up through that pack, through the vent line, and it allows us to separate that from the rest of the circuit and deliver that to the patient down the renal arteries. And here's just a little bit of our dosing strategy. We give initial 500 mLs and then 150 mLs to the kidneys every 10 minutes after that. The beauty about all of this is what I stated in a couple slides prior is the autoregulation feature of the pressure. You know, the renals, they're moving things around. These are complex, long, 8-10 hour long procedures at times, depending on the severity of it. And you can set the pressure to 100 millimeters of mercury. If you're going down 1, if you're going down 2, if you're going down 3 different things, whether it be the renals, whether it be grafts, it can adjust the flow accordingly and the pressure stays the same. So the biggest thing, as we talked about, is pivoting when time matters, right? One thing that we always talk about, if there's an MI, if there's a patient that's down, you know, time is muscle, and we really want to protect that myocardium. So if we are doing changes on the fly, you can actually see in this picture on the left, we have different protocols. Now, for us, because we're really trying to focus on standardization, we only have 3 different protocols. That being said, you can label these whatever you want. You can have surgeon A protocol with this type of plegia, surgeon A with plegia type B. You can have various, you know, I don't know the exact number, but probably double-digit protocols that you can have on the fly. But for us, it's huge. You know, for some patients, we'll use microdelnito. We come off, and then the surgeon's like, you know what, I need to go back in for just 10 minutes, tweak this distal anastomosis. I just want to give microplegia. Can you do that? Within 10 seconds, we're ready to go. We don't have to worry about the long leg time with the heart coming back. And it's just key. And, you know, as Mike Tyson said, you know, everyone has a plan until they get punched in the mouth. And we've all been there where you think you have everything squared away, you're ready to go, you're passing up your lines, and then boom, surgeons changes something on the fly on you. And now it could be a stressful situation. But with this machine, it's really, you know, helped us out and just focus on what we need to at the right time, which is the patient and not the cardioplegia. So just a little bit about the controller overview. I'm assuming that most of you all have seen this, but for those that haven't, and I will say, you know, when we first got this and we were MPS 2 users, it's a lot. It's a lot to look at up front, but with the touch screen, it really is intuitive. And within a couple days, and honestly, within the first case, you kind of get used to it. But in the top left, there's a temperature, and you can actually set a temperature alarm. So if the temperature gets above a certain set temp, we set it at 10 degrees, it'll actually blink at you, so you know you need to do something. You have a real-time EKG, you have your pressure graphs, you have your flow graphs, you can control antegrade, retrograde, what graphs you're going down, which I'll show in a couple slides. But one thing that we really focus on is in the top part of that picture, that green box and that orange box. That's where you can dial in specifically your potassium, your additive, you know, down to your exact ml, down to your exact milliequivalent ml. It really is that specific. And then all this data actually gets pushed into our heart-lung machine, which I'll show in a couple of slides. It'll actually show you time since dose, total cardioplegia, running cardioplegia as it's going. And then you can see to the right of the 243 and 190, those are the pressure alarms that you can change and set accordingly, whether you're going through the graft, whether you're going retrograde, or whether you're going antegrade. So as I was talking about, I think one of the biggest safety algorithms in this machine is the graft perfusion, that auto mode that I circled there in the bottom. You can actually hit that button and it'll auto-regulate flow to your pressure. And here you can actually see the different graphs that you can choose. So if you're going down your LAD and your OM, you can actually select those two and it'll transfer over into your heart-lung machine, as well as it has a hard drive in the system that you can actually see on this display here. You can go retro and down the various graphs. You can go antegrade and down the various graphs. And the beauty is no matter how many graphs you're going to, the pressure will still remain the same. The flow will regulate accordingly. So one of the things that was a game changer for us, and as I said, we use the MPS 2 with the traditional ice bucket, carrying the buckets in, a little archaic years ago, but you know what? It worked. It worked for us. It gave cold cardioplegia. But then as most of the country was aware, this whole mycobacterium hit the entire country and really the entire world of, okay, well, what are we going to do now? We really need to start, cleaning these machines much more frequently. For us, it ended up being an annual cost of $7,000 a year times 6 units, now 7. So it was 48,000. It would be $55,000 a year just in cost. That's not including the staffing costs. And now I'm taking a perfusionist out of the mix, or I'm sending it down to clinical engineering. So we decided to go the MPS 3 ND. We use the CardioQuip, which I believe 70% of the country roughly uses. And we were a little concerned at first, like, will this still give cold cardioplegia? But I can tell you, without a doubt, we're always in single digits. Sometimes I would say on average between 6 and 8 degrees going through that system. We were able to eliminate all water residue. It has its own battery backup. You can actually visually see now with the MPS 3 the cartridges, which you can kind of see in the back of the picture on the left there. So you can actually see the drugs are going in. How many times have you heard the surgeon say, "Are you sure there's potassium in this thing? Are you sure it's getting in?" Well, now you can actually see it. It lights up when you're giving it. It's just that extra set of assurance during stressful situations that you can make sure you're giving the right dose, the right concentration at the right time. And as I shared before, this has its whole hardware in it, so you can have the ability to collect data, review data, and analytics. This is one thing that Amy was saying that we're really passionate about, is not only collecting the data, but finding something useful to do with it. And it's really been a game changer for us in that avenue. So as I shared briefly and earlier in the talk, there are many different ways to skin a cat. And I did make a little disclosure there that there were no animals harmed in the making of this slide. So if you are PETA friendly, so are we. But as you can see, there's 1 to 4, 4 to 1, 1 to 8, microplegia, del nido, crystalloid came on the adult population a few years back. Now micro del nido is coming in various situations. Continuous warm, you can give warm induction, microplegia, and then you're given to cold cardioplegia, which we used to do at our center with fresh MIs. You can give warm induction amino acid, which is almost like a hot shot to get those substrates, to the depleted heart, and then switch to cold cardioplegia. You can do systemic K if it's a redo operation where there's a redo cabbage and they can't get a bulldog on the internal mammary artery. We've done valves where you just can fibrillate. Are you doing high dose versus low dose? Are you doing high volume versus low volume? Is it time-based? Are you giving a hot shot? Are you not giving a hot shot? Is that surgeon dependent, surgery dependent? Are you giving warm blood? Are you not? Same thing. And this isn't even including the permutations of time doses between. If you give one type of cardioplegia, are you giving it every 15 minutes? But that's when you're reminding, and then you're reminding every 5 after that. Are you really actually giving it at 15 or 20? Is it actually more 25? So as you can see, like just as we go over, and this is a short list that probably if I went around the room, we could at the very least double the length of this, of all the different variations. We're trying to do ultimately the same thing, and that's provide the right care, protect the heart, and allow the surgeon to do their work on it. So just a little overview, of what we're doing and what we've done at our center. And I'll be brief because some of this is, probably just a recap, but, blood cardioplegia versus the traditional del nido. It's a depolarizing cardioplegia solution versus del nido, which is the modified depolarizing solution. You have blood cardioplegia, which, yeah, it carries more oxygen to the heart, especially if you have a patient that comes in, with a fresh MI, you feel like internally at least, or at least I do, that I need to provide oxygen to that deprived muscle. And then you have traditional del nido. You're still carrying oxygen to the heart, but just a lot less of it, right? Only about 20%. You have blood cardioplegia, which you have less of a dilutional effect. So ideally, you have higher oxygen delivery, less disruption of that glycocalyx, that fishy, slimy layer on your endothelium. And then also, you're protecting that compromised myocardium with nice cold blood. You're giving it more frequent. With del nido, it's less blood, and you hope that the distribution's good because ideally you're not going to be giving it on average for another 45 minutes. But the upside is you're not interrupting the surgeon, right? So you're not going every 15 minutes reminding the surgeon. They can get the job, that they want to do done, and you're reminding at sometimes 45 minutes, depending on where you're at, maybe a little bit longer. So at our center, historically, we were given blood cardioplasia, and we were only using about 19.2 mLs of crystalloid. So that's great, and then you have the Del Nido cardioplegia where we're reminding the surgeon a lot less, but they're getting hit with that almost a liter of crystalloid up front, which is a big hit. And as oxygen delivery and DO2 started really coming on the field, we started talking about this a little more and more. We started, really focusing on AKI, postoperative delirium, and tried to figure out a way we could come up with a happy medium between these two solutions. Yeah, everyone knows we give potassium to, myocardial depolarization and rapidly stop the heart. The lidocaine we give to block the sodium channels, but more importantly, the calcium channels, right? So the sodium concentration is about 8-to-1 external to internal on the cell. Calcium's 1200 to 1. So really, we're trying to keep the sodium channels closed, but more importantly, it's because of the calcium that we don't want to rush into the heart. And that's why we give the magnesium, is to really act as a competitive inhibitor with those calcium channels. The lidocaine keeps it even closed longer. And then, as everyone, of course, knows, the mannitol is for the osmotic pressure and free radical scavenger. So that brings us to what we've been doing the past couple of years, which we've had incredible results on, is combining the two. How is it some way we can have a blood-based solution, but still have all the concentrations without the interruption of the surgery as much as possible? And it's really taking the Del Nido components and removing that 960 of diluent, but keeping all the drug-based concentrations. And, feeling more comfortable for time in between doses. As I was saying, you have a patient that comes in with a fresh MI, they're doing chest compressions. I always felt a little nervous about, okay, now we're going to give 80% crystalloid, 960 mLs or whatever of crystalloid this patient, a little bit of blood with a little bit of oxygen, and then we're just not going to remind you for 45 minutes. And man, I really hope that distribution is good, and then we're just going to go with it. And to be honest with you, it was surprising. Our outcomes were good, but we saw that big hit in the hematocrit, right? I'm sure we were hemoconcentrating more, which I'll share. I'm sure we were giving blood transfusions more frequently, and we'll talk about the data on that. But really just trying to figure out ways we can not dilute the patient as much, less hemoconcentrating, ideally reduced AKI, increased oxygen delivery, potential reduction and increase in that glycocalyx disruption. So you have less platelet aggregation, less platelet adhesion, more laminar flow in the capillaries. This stuff matters. It's all about the marginal gains. So this is how we do it, which I think is the safest possible platform compared to some other centers I've talked to. I know some have actually, held a syringe in their hand, and then they just try to, give it over the period of the dose, which is fine if you're comfortable, confident, it's a controlled situation. But then if you're not, and then you actually okay, there goes 60 mLs right into the patient. This device is actually FDA approved. It's actually precision-based care. They're controlled pneumatic pumps. It limits the variabilities that exist at some institutions. And we still have the option of giving the microplegia. That's the beauty of all of this. If we think it's a short case and we're not going to be going for a 45-minute cross clamp or longer, we can still switch to microplegia on the fly. If we're getting these patient populations that we want to do something different, it's not a factor. So ultimately, as you can see here, there's two pouches now, cartridges, where one, we put the potassium, it's only potassium. And then the other one, with microplegia, it's really just magnesium in a diluent, which we use Normasol. But with Del Nido, now we're putting the mannitol, the magnesium, the bicarb, and the lidocaine in there. And ultimately, what we want to do is, despite us really trying to put this pathway together, we didn't want to reinvent the wheel. We didn't want to do these crazy concentrations. So we wanted the exact drug concentration per liter of all of these to be the exact same as if we were given crystalloid Del Nido to these patients. And this is a busy slide, but really what I want you to focus on is the yellow, if you get anything out of it. And it's looking at micro del nido versus traditional del nido. And you see the breakdown going down to the yellow numbers, identical. It's absolutely identical. And the difference is if you look at the crystalloid difference between the two, one has 40 mLs, the other one has 962 mLs. So that's a big difference. You know, you talk about having, you know, an 80-year-old lady up there that's a small BSA, or, you know, a 22-year-old congenital, or, you know, pick your poison. You know, that could be the difference between transfusing the patient and not transfusing the patient. That could be the difference between 0 or 2 transfusions. So this is something that we've been really, you know, happy with the way that it's worked at our center. Now, one of the questions that a lot of centers have asked me is, Tyler, do you make this in-house? You know, and for those of you that are in the regulatory field, you may be familiar with the USP 797. Don't ask me why I know this, but I know it because I'm in this. Regulatory has always asked me this. They don't want the perfusionist compounding drugs in the pump room. It has to be done by a pharmacist in a pharmacy underneath a controlled hood. And depending on the bandwidth at your institution, this may be a game changer where they just stop it before it even starts. I can tell you we've worked, and now I believe there's other companies as well, but we originally worked with CAPS that did all the legwork for us. They went through the 503B development, QA validation. They looked at stability studies. And because this is the exact chemical makeup of crystalloid del nido minus the crystalloid, it is the most requested formula. The best part of it, too, is if you're trying to sell this to your institution, it is actually cheaper than a bag of del nido. So it actually could save you financially as well, not to mention the patient outcomes, lengths of stay, mortality rates, so on and so forth. And a 45 beyond use date utilization, I think is good for you know, any institution. Very rarely, if ever, I would go as far as say never, have we had expired syringes at our institution. So always have something measurable. If you're going to do a change like this, which I admit, you know, I'm certainly not the first to do this. There's been others, you know, on various podiums at various conferences that are doing almost the identical, if not the identical same thing. But one thing that's missing, I think, is the data on this. We need to get it out more and show the outcomes. So looking at the average time between doses of our micro del nido versus our microplegia, so you can see. So for microplegia, we remind every 15 minutes. We're not giving every 15 minutes, so on average, we're giving every 20 minutes. And same thing for micro del nido, we remind every 45 minutes, but on average, we're giving every 56 minutes. And then when you look at on the right, the graph, that average total added crystalloid volume just from our cardioplegia, on average, our microplegia patients are seeing about 21 mLs of crystalloid versus the micro del nido of 50. And that's still, you know, it's higher than the microplegia, but think about that 960 that I was talking about with the traditional del nido. And this is for all comers, I should mention. So looking at some other outcomes at our center, and we started this in about 2020. So looking at the reoperation for bleeding, you know, because we wanted to take into account, are we actually, you know, helping the patient with bleeding post-operatively by not giving them this big hit of crystalloid? And although you've seen an uptick in 2022, and we actually now, since then, have created a bleeding checklist, which has been tremendous at our organization. And that's why you can see in that fourth quarter of 2022, all the way through 2023, we've been below that green line, which used to be our mean. Now, these are big jumps, but if you look at the bar on the left, you can see we're literally talking about like 1%, 2%, 3%. Here's our reoperation for bleeding for all procedures, so it's a little bit higher, but still overall, we had that little blip in 2022. We created a bleeding checklist, and now, you know, reoperation for bleeding for all procedures, we're down to 2%, and that's redos, that's multiple valves, valve cabbage, you name it. So intra-op, post-op RBC transfusion rates for isolated cabbage. So are we now giving less blood because we're giving less crystalloid? And the answer is yes. And you can see our numbers are pretty much on par with the national average for isolated cabbages, right around that 22%. And I think, I'm a little bit biased, but I can tell you that the majority of these transfusions are not happening in the OR, right? They're happening in the ICU, and we're trying to tighten up on the nurses post-operative on, calculating those drips accordingly, not just bolusing a liter of Normsol to get that pressure up. Nevertheless, though, we're trending in the right direction. So here's all procedures, so not isolated cabbages, but looking at all procedures. Same thing, since we've been doing that bleeding checklist organizationally, we're now down much below that average. In fact, it looks like if we continue on that trend, when this next report comes out, we'll be able to actually reset that green line. So one thing that I wanted to show that the Quest does is in the center of this screen, you can see the volume. So it tells you the total volume that you gave, the total blood that you gave, the total amount of antegrade, total amount of retrograde. So here on this specific case, we aborted retrograde. That's why the volume is so low. But if you keep working your way down, you can actually see the arrest and additives mLs to the exact tenth of an ml. And you can actually take a deeper dive in there, and it'll actually give you this much lidocaine, this many milligrams, this many mLs, and all that translates over to our record. And I will say, I'm here, just kind of, spitting my own feelings on Quest, but I will say one thing that, Debbie and her team has done an amazing job is being collaborative with other industry leaders as well. And I can tell you, Alex Agassi from Spectrum is our heart-lung machine that we use. They worked with Quest. We got them together. And as you can see, all that data on the left translates right into our heart-lung machine. And it tells you how much total volume you gave, how much additive, how much cardioplegia we gave, temperature, so on and so forth. This is the way that industry should be collaborating. This is what we should be pushing all of industry doing, is collaborating with each other to produce the best possible outcomes. And this is just a sentiment to the great team that Debbie has produced around her. I can tell you going into this, I was like, oh, this is going to be, a headache trying to get it. It was seamless. Within a week, we had this up and running, which was just, an incredible sentiment to their quality efforts, in collaboration of this. And same thing. So on the left here, you can actually see, our dashboard, which we present to the entire OR. Don't make it a me problem, make it a we problem, make it, something that the entire team is looking at, the surgeon's looking at. We can look at maps, we can look at oxygen deliveries, we can look at area under the curves. This stuff matters. If you want to use that cardioplegia and help it drive outcomes, everyone has to be on the same page. And on the right, is a picture, and I just wanted to show, how small it is, because I believe it is, I know it's much smaller. I think it's 44% lighter than the MPS 2, but we push these in and out of the ORs every day. And we have some small people on the team. We have some larger people. This is a relatively light machine to move around. It's very compact. It's very organized. And on the left, we use the reservoir with the NX19, which if you can get your hands on it, has been a game changer for us organizationally. And we'll just save that for another talk, but it's just been absolutely incredible to use that and partner with all these industry leaders trying to put together the best package for the patient. So why does this stuff matter, right? Why do we even care? Like, are you really making a difference? And I just wanted to pull up two papers real quick. One which came out of Lancet, which was looking at short-term treatment of iron for patients going into cardiac surgery. This was a behavior change for us organizationally. When a patient comes in with a low hematocrit, it automatically triggers a heme consult. We automatically give them 200 milligrams of iron sucrose. And what this top paper showed was, despite only giving it as close as 5 days pre-op, there was increase in hemoglobin concentration, increase in reticulocyte, increase in reticulocyte hemoglobin. For those that don't know, reticulocytes are these immature red cells that are going to, one day grow up to be red cells. But, we talked about that post-operative care in the ICU where they're doing the transfusions, where they're giving these boluses of crystalloid, and they noticed that these help to reduce adverse events. And then the bottom one, which is absolutely fascinating, they looked at 24,000 patients and risk-adjusted all of them. And independent of sender variability on transfusion, they noticed a 9% increase in mortality, 7% increase in morbidity, major morbidity, and 4% increase in minor morbidity for every single unit of red blood cells given. Every single unit. So as much as you can avoid giving red cells, we should try to do it. We know this as perfusionists, but the data is showing it. The data is showing it, and it's all these little small tweaks that add up to these marginal gains, which then ultimately add up to an exponential result. One thing we're going to be looking at now, this paper that came out of Oshita, that because of the data and that we're able to get, and because of the work that we're able to do with Quest, we can actually look at specific oxygen delivery intervals. And so what he found out is anytime that you are under 1,500 or over 1,500 for your area under the curve, anytime you have a single interval greater than 880, or anytime you give more than 2 units on bypass, these are all independent indicators of AKI. And these are going to be coming out at our center. This is actually hot off the press. In the next couple of months, we're hoping to really track these intervals and pull meaningful data, because the number always varies, right? What is that number of oxygen delivery we should look at? Is it 260? Is it 272? Is it 300? We don't know, but I'll tell you one thing. I want to find out what it is at my center, not at other centers, not in Italy. I want to find what it is at Portland, Maine, and we're going to find it. We're pulling data right now, and as these future algorithms come up, I just really urge you, if you have the capability, get this in your forefront, and if not, make a pitch to your quality team, because these do add up, and these are not only financial savings, but patient savings at the same time. So future considerations, just to kind of wrap up the talk. And I know, and I was almost going to simplify it, but some people like looking at data like I do. All the numbers on the right. And this we pulled from, a year back, but all comers on microplegia, everyone that comes in. So isolated CABG, whatever we're doing, surgeon preference, we only hemoconcentrate 5% of the time. Crystalloid del nido, which is not surprising, we're hemoconcentrating 17% of the time, which is much, much higher. Then when we looked at our AKI rates, we noticed that 17% of the patients with AKI were hemoconcentrated. Patients that didn't have AKI, hemoconcentrated much less, right? Almost half as much. So whatever we do, we're trying to reduce hemoconcentration. Now we're really trying to figure out how we can do a randomized controlled trial between not only micro del nido and traditional del nido, but micro del nido and microplegia. Look at post-operative factors that now we have a baseline. Remember that data, what are you going to do with it? You have to establish a baseline sometime at some point. And ultimately serve patients better that have pre-surgical kidney insult, chronic kidney disease. What are we going to do? How are we going to treat those patients pre-operatively, customize the care around the patient, reduce the permutations in the OR. Don't customize the care to the surgeon or the perfusionist, but do it to the patient. And the last 2 things I just wanted to bring up is we're looking at funding now to look at glycocalyx disruption with actual biomarkers that we're working with. We actually have a research institute at Maine Medical Center, MMCRI, that looks at those biomarkers that we've already established in our organization. And then lastly, AI is the future. And it's something that we're working with right now with Northeastern University up in Boston that's partnering with us, that's actually collecting all these data points that we're pulling in from the Quest, all these data points that we're pulling in from the heart-lung machine, and taking all that data and ultimately going up to the ICU saying, this was the intraoperative data, this is how you should treat your patient post-operatively. And that's going to be coming in the next couple of years. They just did a couple poster presentations around the country with Northeastern University. and some really exciting stuff that's going to be coming on our platform and our profession in the next few years. Lastly, I just wanted to do a shout out to my team. As you can see, they're on the top right. I love this. It's my first time at this meeting, but so far, you know, you got the Bloody Mary bar. We're in a beautiful landscape here. It's a great meeting. Without them, I wouldn't be here and I couldn't do this. So with that being said, I just wanted to thank Quest for giving me the platform here, and thanks for allowing me the time to talk. Any questions? Does anyone have any? I don't know if we have time for, or if not, then okay.
I have a question for the room. How many MPS users are in the room today? How many 4-to-1 users are in the room today? Nice.
Hey, Tyler, really
Jim,
nice
good to see you.
job. Good to
Thanks.
see you. You know, changing cardioplegia is just a huge task. It's voodoo for a lot of surgeons, right? I've been using this forever. I have never had any problems. Why should I change? So congratulations on what you've done. My question is, so I'm pediatrics. We used Del Nido in the original formula, the 1-to-4 blood to crystalloid. I know it's catching on quite a bit in adults, and the microplegia aspect is catching on. One of the questions that I have for you, I wonder, one of the big selling points on Del Nido, I guess, or one of the primary goals was to reduce the calcium load. When you remove that crystalloid and you put a lot of blood back in, was there any consideration to that piece of it? If you're given primarily the blood that's there, which has a normal calcium, you're not washing out the calcium. Clearly it's got potassium stuff in the heart. You're not having any issues. I was just wondering if there was thoughts around that would that kind of go away from one of the main reasons for using Del Nido in the first place?
Yeah, I can tell you from a pediatric standpoint, same thing, Jim. We're still using traditional Del Nido. And we still, I will say too, when we make up the traditional Del Nido, we still use a patient's blood to do that when we can wrap the patient. But I can tell you lidocaine has been an absolute game changer with shutting down those channels. And we have a radiometer ABL90, so we're monitoring calciums frequently. And it's not a calculated measurement, it's a direct measurement. We haven't seen any issues. In fact, we haven't seen any higher calciums. We haven't seen, and one of the things too is we were worried about, is the heart going to be sluggish when the cross clamp comes off, because of this. And I'll tell you, it pops right back every single time. And I don't know if it's just with the larger patient population, it's less of a concern than as you're stating, like in the pediatric population. But I can tell you on the adult side where we're using it, we haven't had any issue. And, I know a lot of people have been trying to pin down Pedro, Dr. Del Nido, on this, and I've heard him talk many times, and he's one of those things that I don't endorse it, but in my head, it makes sense for the adult population.
Sure.
And, same thing, we've seen the same results.
Great.
Yeah.
Thanks.
Yep.
Just a quick question. When you switched, did you see any changes in new onset of AFib?
No. No. Short answer, no.
Okay.
Some people online want to know if there's any evidence that specifically addresses the cost of the system and money-saving outcomes.
I didn't want to get into the cost because that may be institutional and also depending on the volume, but I can tell you look into it, and I'm hesitant to give a dollar amount, but I can tell you it adds up to be thousands of dollars a year. If you're just looking at micro Del Nido syringes versus crystalloid Del Nido, and you're not making it in-house and you're buying it, then I can just say from us, we're saving thousands of dollars if you just look at it from that aspect. Now, that being said, I shared with that you could get it from an outside source. We're actually making it internally now through our own pharmacy. Yep. Awesome. Thank you so much, everyone.